Thank you so much, everyone. It's a really fantastic talks. I thoroughly enjoyed each one of these talks. So in addition to the speakers, allow me to welcome Dr. Stephanie DiGiorgio, who is a primary care physician, who is one of the leading figures in primary care regarding women health as well as mental health, and an obesity expert as well. Please allow me to also introduce Christine Alexander, who is a person with living experience with obesity as well as diabetes. Mary O'Kane, who is known to probably all of us, a consultant senior dietitian, and Dr. Jennifer Logue, who is a reader in metabolic medicine and obesity at the University of Lancaster, if I can remember correctly, because she keeps moving all the time. So welcome you all. And I will just start with the question, and I will start with Christine. So you lived with obesity, you had diabetes. You've heard from 3 speakers talking about the role of different dietary intervention, the role of processed food, ultra-processed food, low-fat, low-carb, ketogenic diets, whatever, the 2 to 5, time-restricted eating. I think the list can go on forever, and as well as the role of bariatric surgery. So as a person who require treatment for diabetes, and you may want or you don't want treatment for obesity, how do you feel about this? What do you think? How do you think patients can even handle that treatment for themselves? How does the patient feel about all these interventions from your perspective?
Answer that question in a few minutes is very difficult, but it's been very interesting to hear this all from the other side of the fence. I did in fact have a Roux-en-Y gastric bypass in 2015. I lost 10 stone at the time, which enabled me to carry on working. I'm a CEO of a health and social care charity, and in fact I was facing potential having to give up work at a very early age. And kept asking myself the question, why is it that someone with a reasonable level of intelligence doesn't know the answer to this question? And there's a huge amount of shame that's connected with obesity, which is really difficult to navigate, whether you are extremely obese or whether you're slightly obese. There's an enormous taboo around weight gain, and it's difficult to talk about. Very interested to hear what Kamal said about the hoops that one has to jump through. I did navigate that road for a year or so with my own GP, and in the end I was in the very fortunate position that I could actually pay for surgery privately, which is what I did, and I'm very glad I am too that I did so. I had type 2 diabetes. I'd been diagnosed, and interestingly, when one suffers with this condition, we almost wait for the trigger. So what is the trigger that causes the change? And you ask yourself why each event that comes along is not that trigger. And for me, the trigger was being told that I had type 2 diabetes. I don't know why. I'd never thought about it in advance of that time, but that was the moment when I thought something's got to change. And that's when I contacted my surgeon and arranged to have surgery. And from the moment I met him, I had surgery 6 weeks later. There was no waiting. There was no time to think any more about it. It was a clear decision. It had to be done. So I think that the mental health aspects of obesity are an enormous weight on a patient. The compounded impact of continued weight gain only makes it even more difficult to come to a decision. And I think Kamal is right, that actually trying to enable and empower patients to feel in control of that decision is a huge part of what needs to change in order for patients themselves to feel as if they can get some measure of control back again. And that would be my view from my side of the fence and my own journey.
Thank you very much for that, Christine. So I'll move this to Stephanie and Jennifer. I'll ask Stephanie first and then Jennifer the same question. So the patient now has many options when it comes to diabetes remission. We know diabetes remission is achievable. We know that there is a variety of interventions between dietary interventions and bariatric surgery, and we might have pharmacotherapy options in the future. So how do you actually approach this when you see your patient with the type 2 diabetes, especially if they are relatively newly diagnosed? Do you think about remission? What do you discuss with them about remission? Or is it something that you think there's just no time for it to talk about, so we'll just leave it?
think initially you're just, if they're symptomatic particularly, you're trying to get the symptoms under control. And that's going to be the first thing that really matters to that patient and that patient's health sort of in the immediacy. I think the idea of getting type 2 diabetes into remission is actually quite new, really, amongst primary care. And I think that we haven't really had that discussion, and I still don't think it takes place very often. I know when we talk about patients having options, there are a lot of theoretical options, but they're not all available to patients at the moment. And, you know, it's incredibly hard. Like Christine, I didn't have type 2 diabetes, but I had to go privately for surgery. I couldn't navigate the NHS pathways. I wasn't fat enough, or I wasn't this enough, or I couldn't wait long enough, and so the real options are limited at the moment. And I think we have to spend a lot of time now improving that and campaigning for that, because we do have these options. And even putting people on meal replacement and trying to do it that way, which Jennifer will probably talk about a lot more, you know, those aren't real options for most people at the moment. So in primary care, I have to say, we're not quite there. I think we need to up our game and do better.
Thank you, Stephanie. Jennifer.
Yeah, thanks. So I would totally agree with what's just been said. And I was actually particularly with what Christine was saying about people's reasons and wants for weight management. And it is really difficult. So I actually diagnose a lot of people with type 2 diabetes, not in my obesity work, but in my cardiovascular risk work, because quite often raised lipids are a sign of developing type 2 diabetes, and it quite often happens. And I think what's really worth pointing out to people that work in weight management services is that the patients that you see in front of you that have made their way to their weight management services have gone through quite a lot to have got to that point. And there's a lot that those of us that are actually sometimes referring into those services have done. And they do not represent actually the whole body of individuals that are out there. And there are people that do want to do things. There are people that have the means to do things. And obviously I always talk to people about it. I have the time and the skills to do that. But what I don't have, particularly since I moved, as you pointed out, is I no longer actually have access to services that I can refer people to. So I'm really stuck actually as to what I can do. I can't refer people to a tier 2 service or a tier 3 service or a bariatric surgery service. I can refer them, well, I can signpost them to diabetes prevention program. But if they've already got diabetes, it's a bit more difficult as well, as you know. I also think as well, and I know we're not quite talking about this, but you know, we're talking about the diet and what you refer people to, but actually that's just one very small part of weight management. And weight management is a really complex intervention that involves behavior change and psychology, and, you know, obviously triaging for other underlying conditions, being able to support people, providing peer support and forward into maintenance. And actually we get so fixated about the diet or the bariatric surgery or the dietary intervention and forget actually that all these other parts are probably equally, if not actually more important. And having that framework for being able to support people to make the dietary choices they want to, and to be able to change. That doesn't involve actually having to leave a whole service and get referred into something else. Have to make those changes that what suits them. You know, Emily put it very well. It's what you can afford. I work in one of the most, well, in fact, I work in the most deprived area in England, second only to where I've just left in Glasgow in terms of the UK deprivation. And what people can afford and what is normal for eating did not look anything like, you know, obviously the plates presented in Kevin's study. And we have to be mindful of that as well in what we do and what we offer people.
Thank you very much, Jennifer. I obviously totally agree with all what you've said, and Stephanie as well. The lack of services and the lack of options and not addressing the social inequalities will hamper any meaningful understanding of the science to be translated to really any real life benefit. And I would like to ask Mary and Emily a question about So, okay, we understand dietary interventions can achieve good results. We know that for each dietary trial, only the minority actually sign up to the trial. Most of the people you approach to actually to go to any dietary intervention will just say, thank you very much, I don't want to do that. So first of all, there is the patients may not be very willing to do. But more importantly, do we actually study the diet, or do we study the package that goes with the diet? I mean, is this the benefit of the dietary intervention itself, or is just simply all the other package that comes with it? Saying that the intervention is not useful, please don't get me wrong, but I'm saying it is just not the diet, isn't it? It's actually all the other supportive stuff that happens with it, because you very rarely match for that sort of support between trials arm. I'll ask Emily first, and then I'll go to Mary. What do you think, Emily?
I think that's a good point about support. Like the most effective diet approach are the one which have an important behavioral component, because there's an important part of relearning about food, and that support might be within the trial, but we know as well with certain diet types, there's a lot of community support, like big groups that support dieters in following a certain path, and that is kind of really important as much as the package, because when we look at those studies, often what is reported is the intent of dietary change, but not necessarily what people actually do. And that's what you don't see in meta-analysis. And often you see that it's not that much divergence in what's achieved.
Thank you, Emily. Mary, what do you think? Diet, package, support?
I think this support is really, really important. Obviously, I've been a dietitian for a long, long time and followed lots of diet studies, and even like going back to the 80s, knowing that from the trials that if people really were following the diet that they're supposedly on, the weight loss would be far greater, just because sometimes the diets were so strict. And what I see in practice is that people will come saying they prefer a certain type of diet or they're following a certain diet. But as Emily said, that when in practice they might not be doing that. And it doesn't, to me, it doesn't really matter whether it's a low carbohydrate diet, high protein, whether it's low fat. It's what works for that person. So I've seen over the years, sometimes I have to go on Google and actually look the diet up while the patient's with me. I want to make sure that it's safe, they're getting the micronutrients they need. But it's actually helping support that patient make the changes, listening to them. And so often, when we see people, they say it's actually the first time they've actually been listened to by a healthcare professional. And I think that makes such a difference. And what we're doing is helping them with the journey. And it might be a particular type of diet. And for other patients, it's helping them go on to bariatric surgery and helping with support them afterwards. So I don't think there's any, I agree with all the presentations. There's no a perfect answer for a diet. I think it's all the support and actually helping that person move towards the treatment that's going to give them the best results.
So I'll move to Kevin, and I gave Kevin way too much break for now. See, I need to keep him awake with us. I'll pick up on the point that Emily mentioned. And Emily said, obviously, that yes, in the trial, especially the longer trial, the intervention, but what people do on the ground could be different to the intended intervention to varying degrees. Obviously, that's the beauty of your studies, that you've showed us that we know exactly what these people had in terms of their diet, because they are 14-day trials that shed a huge amount of insight into mechanisms. But obviously, the longer term picture could be a lot more difficult to assess and a lot more muddy in terms of what is better than what. So from the work you've done, are you moving more towards saying is actually the macronutrient doesn't matter? It is the ultra processed food which seems to be driving the problem, at least let's say in the US where the studies are done?
I think so. A couple points there. I completely agree that different types of studies address different types of questions. So I think one of the things that we talked about is even diet intervention studies that are done on longer timescales with more subjects. They're a test of the advice to stick to certain diets and the support mechanisms and all of the package that comes along with it. Whereas, I'm a simple physiologist. I just want to understand what the effect of the diet per se is, keep everything else constant. So in that sense, that's why we do this kinds of studies that we do. And those kinds of questions are very different. I mean, we are specifically interested in the physiological effects of these different diets. And so, I mean, one of the things that when you say, does it matter? I guess the question is, does it matter for what? And from a very practical standpoint, if someone finds it, one type of diet a lot more enjoyable and easy to fit into their lifestyle, and many people in their family are already doing it, then yeah, of course, they're probably going to be more successful on that kind of diet than another kind of diet. The other thing is that, at least in our studies, when we are investigating the diet per se, yeah, it might not matter so much in terms of, fat loss or something like that, but it might make a big difference if you're looking at glycemia, right? So when people actually are on these diets and that they're on those diets, I mean, I think you saw those glucose and insulin curves, they're hugely different. And I think that has potentially clinically meaningful benefits for some people, regardless of the number of calories that they're eating. So I think that there is a lot of justified, excitement about the possibility of very low carbohydrate ketogenic diets for remission of type 2 diabetes. Although we didn't study type 2 diabetes, you can see clearly that glucose levels and excursions are much, much lower when eating very low carbohydrate meals. So, but translating that to the real world is, I think, a very big challenge, and it comes to folks, the rest of the folks on this panel, to kind of do those kinds of things. I'm going to still be sticking to our physiology studies, try to better understand mechanisms, seeing how the body responds to these known different diet changes.
Oh, Kevin, I can assure you, we absolutely love your studies. I mean, they're absolutely amazing. I personally, on a personal level, I always keep an eye on what you are publishing. It's absolutely fascinating. Can I just ask you another question, which is, let's forget the environmental factors, the social demographics, who's dieting in the family, whether they can afford the diet or not. And if we talk just from a scientific point of view, mechanistic point of view, is there any possibility, and I appreciate the studies that you've shown against the carbohydrate insulin model, but is there any possibility that there is a variety or a heterogeneity in the pathogenesis of the disease? In this case, let's say obesity, for example, where actually for some people, carbohydrates could be the intervention, and for some people, the low fat could be the best intervention. And let's say, for example, for some people, it could be the carbohydrate insulin model may be correct for some people, not for everyone.
Yeah, I mean, I think it's certainly possible that there's a variety of mechanisms that give rise to, what seems at a very gross standpoint a homogeneous disorder, but is in fact very heterogeneous. And there are distinct biological mechanisms and distinct responders versus non-responders that have a biological basis. And I think that that's, a big push behind sort of precision nutrition and precision medicine, is to try to better understand these subcategories of people. What I tend to push back on, however, is I say, okay, yes, that's certainly a possibility, and it's an exciting area of research, but we shouldn't presume that that's the major difference. So in those waterfall plots that Amelie showed very nicely from the Diet Fit study, it was not a crossover study. So we don't know that the person who did extremely well on the low fat diet wouldn't also have done equally well on the low carb diet. I think that there's a knee-jerk reaction, especially in the biomedical research community, to presume that inter-individual variability in response is some biological mechanism that we can dissect, whereas it might just be that person was in the right time in their life to kind of make a change, and they had the right support system and the right wherewithal to make that change. And if you'd assigned them to the other diet, they would have done equally well. And so I think we need a combination of studies that are actually crossover studies, like the ones that we do, to kind of better distinguish that. One thing I didn't show, I showed the homogeneous response for the low carb versus low fat diet study in terms of energy intake. But in the ultra processed diet study, that was not the case. There were some people who were completely immune to the different diets and ate more or less the same number of calories, and some people who ate more than 1,000 calories a day differently on the two diets. The mean ended up being about 500. Why was that? And is it reproducible? So I think that there's a lot of excitement in the area of precision nutrition, precision medicine, but I think we are at risk of hyping it up a little bit too much at this point, and we need to do more reproducibility studies and better methods to kind of really try to assess this and not assume that it's all just biological variability.
Thank you very much for that, Kevin. And I think part of the pressure, I think, is coming from the fact that, yes, we still actually have very unknown answers, unanswered questions in the fields of obesity and type 2 diabetes from obesity management and dietary intervention perspectives. But obviously people are suffering from the disease. The disease is very common, and there is a lot of industry, commercial interest in this. So you find all sorts of different diets, and everybody is sure that their diet is the right one because it worked for me and it worked for another 10 people I know. And I think that's why we're sort of the treatment is running way ahead of actually our own understanding, and we try to stay on the fence all the time, and it is hard, I have to admit. But that's very insightful answer. Thank you very much, Kevin. Kamal, as a bariatric surgeon, I'm going to make a very big assumption here. You may disagree with it. I'm sure you would like to operate on a lot of people with type 2 diabetes, but we know that, as you said, this is not scalable. You are not going to operate on 10% of the UK population who have type 2 diabetes. We also know that services are limited. We also know that about half the patients do not want to have bariatric surgery. But we also know that there is a lot of people who would love to have bariatric surgery and they can't access it. But from your point of view, if somebody who is newly diagnosed with type 2 diabetes come to a clinician and say, I would like bariatric surgery because I'm interested in diabetes remission. Obviously, this is slightly artificial, but I'll try to emphasize a point. Do you think we should offer them bariatric surgery at that stage? Or do you think we should have a word with them and say, why don't you try TDR, total diet replacement? Or why don't you try another intensive lifestyle intervention before I offer you bariatric surgery? What are your views about this?
Thank you, Abdul. This is, I think, a very, very pointed question. So I'd tackle your first assumption, if I may say, that I would like to do more operations. I'd like to help more patients. And if I can help more by operating less, then so be it, you know. So I think we must think that surgeons are a part of the fraternity, and we all mean this. We have the same outlook, which is to help more patients and not to do more operations. But as it happens, you know, if surgery is more effective treatment, then I said, again, you know, you mustn't leave it to me to push for it. You should all push for it because that would be in your patient's interest. Your second point, I think when we're talking about the heterogeneity of the patient population, I agree with both you and Kevin. And I think what I see in my practice is that patients who suffer from obesity have a variety of metabolic responses. So we know that a third of patients who are seeking bariatric surgery suffer from type 2 diabetes, where all are by definition more than BMI 35. So we see that not everybody with a body mass index of more than 35 has the same degree of metabolic compromise. So when you ask me a specific question about metabolic compromise or type 2 diabetes, I would then also see what other benefits can I offer this individual. So for example, if the individual has a body mass index of 50, and then has other problems as well, then it's a no-brainer to me. Because this surgery is not just a surgery which will help diabetes, it also helps, as I said earlier, it also gives profound weight loss. And with that, other multiple benefits. So when we look at the patients with type 2 diabetes in a spectrum, if you go from the higher body mass index to lower body mass index, fully aware that body mass index is not the only way to look at obesity, I think the usefulness of surgery declines gradually. Where in that spectrum is the cutoff? We know from the guidance, the cutoff is at between 35 to 30, somewhere. So I think that individual, if they had a BMI of less than 30, I would advise them that the chances of surgery working for you or giving you lots of benefits over risks is possibly not there at the moment. Whereas if that individual has a body mass index of 35 plus, then I would be saying, well, if you've tried everything else for 6 months, 12 months, and if it hasn't worked, then I think you're realistically going to need surgery. Otherwise, you'll end up on insulin.
Stephanie, want to say so? Apologies, Kamal. Yeah, carry on.
No, I was going to ask a question of Kamal, if I may, on the basis of that. And you're quite right that we know that patients who have obesity have very different fat deposition. So there'll be people who are much higher visceral fat, either due to their ethnic background or just the way that they're made compared to different people. So do you think we should be thinking about that much more when we see our patients and referring people whose BMI might be lower, but we're pretty aware that it's all central and we need to get them to see you as a possibility of someone who could be benefiting from surgery sooner rather than later?
So again, Stephanie, it's a great point. And we know that bariatric surgical community by and large is working on the 1991 NIH consensus guidelines. And in soon to be 2021, we're 30 years behind that curve, right? So what we are suggesting, what we're talking about here is a disease which is so complex that we don't understand it. So because clinicians need some guidance to work with, we've used the cutoff of BMI 35 for a long time, knowing that above BMI 35, most individuals are going to have some significant severe consequences of living with obesity. And as you go down the lower body mass index, that becomes less and less clear. I'm very aware of some individuals with a body mass index of 31 or 29 even, who have profound metabolic syndrome, and they should be offered surgery. But they don't meet within the current guidance framework, because I think we're limited by how we have defined the obesity and metabolic syndrome. And I'm sure Abd is nodding there. We need to come up with better definitions. I know that Dr. Sharma's group in Canada has been pushing for these definitions for a long time, but I think clinically we haven't moved there. So that's what I would like to see personally, because I know that some individuals with a body mass index of 50 plus aren't that ill, as opposed to some who have a body mass index of 30 and they are metabolically ill.
Thank you. Jennifer, please.
I just actually had to check the title of this particular session there, sorry. So we're talking about dietary, well, we're talking about interventions to treat type 2 diabetes. And yet we seem to be talking a lot about type 2 diabetes remission as if they are exactly the same thing, which to me they're not. Diabetes remission is it's a line in the sand, it's a biochemical measure. And actually, you know, I think Kamal said something really important earlier, which was about the fact that we have to be realistic. We can't give bariatric surgery to everyone. And who do we give it to? And actually, if you get somebody with a very high HbA1c on a lot of medications, perhaps on insulin, and even if you get that insulin right down, you improve all their complications, that might be far more useful thing to be concentrating on than getting somebody from, and I'll talk in old money because I find it easier, from 7.1 to 6.9 in HbA1c. In all the diabetes remission studies, the people that got remission were the people closest to that line in the sand for diabetes anyway. It's not they had a bigger effect. I also just again want to bring up this point that the people that Kamal will see, or the people that Mary will see, or the people that I will see with a different hat on, are the people that have struggled with other things to get to that point, and not everyone will. I see a lot of people who get below that magic line from, you know, HbA1c 48, and they're not doing it through total dietary replacement. They're not doing it through bariatric surgery, both things that cost several thousands of pounds. They are doing it by themselves, like the vast majority of people that lose weight in the world are doing. And there is a subsection of people that doesn't work for, and we're not very good at picking out who those are, and we're not very good yet at really helping with treating them properly so that people feel they can come back and say, that didn't work for me, what can I try next? Without the burden that brings. And that's what we need to work out, rather than going, well, everyone that suddenly gets above that magic line needs bariatric surgery. No, they don't. The vast majority of people don't want it and will be fine.
Thank you very much, Jennifer. I personally have concerns about the issue of remission. I think it's an important concept, but it might distract us from the actual main aim of treatment in people with type 2 diabetes. We are running out of time, so I'm going to just finish with one point from Christine, and then we'll close the webinar. Christine, you seek treatment. How important for you was this concept of diabetes remission? Was it even suggested to you at all during the discussions? And did you find it important, or was it just a secondary issue for you?
No, it was important. And as I said earlier, it was the trigger that caused me to seek out treatment in the first place. There were a number of different conditions, joints, high blood pressure, reflux, whole host of different symptoms, which were discussed at the first consultation with the surgeon. And in fact, all of those things have gone. I know that doesn't happen with everybody. I've been extremely fortunate, but general health improved 300% for me personally. So bariatric surgery was not, it was not just about type 2 diabetes. that was the trigger and the start, but it had so many other health benefits, not least of which was to keep me working, and hopefully for a good many years yet, which was certainly in jeopardy at that time.
Thank you very much, Christine. So for that, I would like really to thank all the speakers, all the panelists. I very much enjoyed my time discussing with you and listening to you. I hope you enjoyed your time too. Thank you very much for giving up your time for free to participate in this. Thank you to the audience. Thank you to Novo Nordisk for the sponsorship, and goodbye. And hopefully we'll see you in the next webinar in November. Take good care of yourselves.